So the other thing you guys have here that we don't have a lot of, or it seems like you have here, is at least a semi-reasonable population of healthy people. So what I'm going to talk about may or may not apply so much to some of your practices, but nonetheless it's something that's been neglected over some time here. So I've noticed in this disclosures I'm going to talk about a couple of devices that are made by companies, but I have no relationships with any of those. I put this in here so when we think about some of these cerebrovascular topics, it kind of helps to go on a timeline. And so basically what's happened here is that cardiology, they kind of took the front runner in this topic. And so with angioplasty and thrombolysis for acute MI, and then came stroke. So as most of you probably know now, we had about 50 or 70 trials that were negative for acute intervention for acute stroke, and now in the last year we've had 4 that are positive, so now everybody's jumping on. So it's pretty similar to what Dr. Nelson mentioned earlier. We don't have a lot of evidence for some of the stuff that we do. And so if you look at this in terms of acute non-traumatic intracranial hemorrhage, we have a couple of trials here, and now going forward in 2015 where we have. And so the reason this topic is at least somewhat important is that this makes up a pretty good population of all stroke patients, 80,000 cases a year in the United States and 2 million worldwide. And then this is really the kicker here, is that the 30-day mortality is 50%. And the 90-day mortality is even higher than that. A lot of this depends on the patient's age, their comorbidities, and the size and location of the hemorrhage, but nonetheless, all comers, 30-day mortality of 50%. And so keep that in mind as we go forward talking here, because there's a number of different ways to measure success in therapies for intracranial hemorrhage as well, and I'll propose a couple of options here. But and then the one other thing to keep in mind is that about 50% of them also have a ventricular component, and that may play a significant role when we talk about the outcomes. And so I messed this slide up a little bit. I was just gonna, and I didn't really understand how the questions thing worked either. But I would have asked, if this patient on the left side of the screen there, came into the hospital, you have to think about, say the GCS is 12 or 13, and the patient's hemiplegic. I guess if you have to think about that, you have to think, well, am I going to operate on this or not? And traditionally, I think, at least in the recent past, a lot of us have said not. We've waited on this, and a lot of these patients with basal ganglia hemorrhage, hypertensive hemorrhage, and whatnot, they kind of linger around the hospital for a while, and they get worse before they get better. And that's kind of what I was showing here. So one of the things we're going to try to avoid here is the early hematural expansion. This is a patient I took care of in Cleveland early in my time there. And but before they got to us, this is what had happened from a 2-hour time point. And obviously this hemorrhage on the right side here is essentially non-survivable at that point. The second thing that we try to prevent is this secondary injury. The thing that we try to prevent secondarily is this secondary injury. So patients get vasogenic edema, and there's been a number of studies that have showed that the blood is actually neurotoxic. And so by getting the blood out of there, there's some thought that we may be able to prevent some of the secondary injury in these patients. What we've done in the past with some of these patients, it doesn't look much better. So this is what, without removing too much of the clot, we do decompressive hemicraniectomy, and I think anybody, radiologist or otherwise, would agree that these scans on the right side don't look too good. There's significant swelling there, and pretty significant secondary injury going on, and those patients don't tend to get a lot better. And so I think that there's a lot of option here that we can do better than this. And so I kind of wanted to just review this from an overall standpoint, but When you're looking at these surgical trials, you have to look at timing and you have to look at invasiveness, because I think both things play a role in outcomes for this particular pathology. And so you can go anywhere from minimally invasive and early, which I'm going to argue will be the best option, to big craniotomy, maximally invasive, and late. And for the reasons that I just mentioned earlier, I'm going to argue that that's not going to be the best option. A couple of busy slides here. I won't talk too much about these things here, but these basically summarize the literature on this. And so there's not really a lot of good literature. There's a couple of good studies. The one that's been reported as positive is this one here from 1996, which compared endoscopic evacuation to best medical treatment. So that they did have somewhat of a benefit of death or disability at 6 months in that study. But the bigger studies that have been done, I'm going to talk about in a little more detail, are these stitch trials, 1 and 2. And then there's another trial called MISTY that has just been reported recently. And so I also made another slide that's also way too busy, but it basically summarizes the minimally invasive versus standard craniotomy. And you can see that there's some trend toward better outcomes with minimally invasive, but I won't spend too much time on that. There is a guideline for acute intracerebral hemorrhage, and basically it says that we don't know what to do for the most part. There's not very great evidence there. And so for patients with supratentorial ICH, the usefulness of surgery is not well established. That's one of the things that we know. The one group of patients, the one group of patients that we do know that surgery is beneficial for are patients with cerebellar hemorrhage that are declining neurologically. We used to actually place external ventricular drains in those patients with hydrocephalus, but at least according to the guidelines, those patients are better for surgery at this point. Skip through this a little bit faster here because I end up having a lot of slides. So these stitch trials, these trials basically tried to look at patients that came with acute non-traumatic intracranial hemorrhage, and they randomized these patients to best medical management versus surgery. Surgery in these trials was a craniotomy, so it was essentially maximally invasive. They were basically just trying to get the blood out, and in terms of what brain they damaged, that was sort of collateral damage, I guess. And so there was some slight trends in the stitch 1 towards benefit with surgery, but when you analyze this with statistical methods, it wasn't very good. The one thing that I will have you keep in mind, though, is that when they said there was no surgical benefit, that 26% of the patients in this particular study and 21% of the patients in its sister, that I'm going to talk about next, crossed over from medicine to surgery because they declined. So there's some benefit there in terms of saving life at least, but in terms of outcomes it may not be as clear. This is the stitch 2. So basically they tried to do this earlier. They randomized the patients within 72 hours and then operated within 24 hours, so that wasn't necessarily all that early, within 4 days. They found actually a benefit, a clinical benefit in patients that had superficial hemorrhages that were easily accessible. And so that's the subpopulation of patients that we're kind of looking at here. When you broke this down with the statistics, the Kaplan-Meier curves, and this is a Glasgow outcome score, so you can see that there is certainly a slightly higher proportion of patients that got surgery that had better outcomes here. So there's a slight line. I'll show you that when it comes to MISTY here in a second. This is a more recent trial, this MISTY trial, where they put a stereotactic catheter and then gave TPA into the hemorrhage. So their original goal of this study was sort of to prove safety, and so they had to wait for stability. If the hemorrhage was expanding, you don't want to put TPA in that. So they waited for stability, and then they would put a catheter, they would put some TPA in there, and their length of treatment was about 3 days. And what you can see here is that the clot volume in the surgical group was significantly less, and the edema volume that developed in terms of secondary injury was significantly less. And that was what they published. And then at the ISC a couple of years ago, they showed their outcomes at 365 days. And so in terms of ranking 3 or better, the difference was absolute difference was 14%. So that certainly showed a trend in useful in-store surgery, but the outcomes at 180 days was 11%, so you can see that these patients do take a while to get better. Now the other problem with these types of studies is the same as stroke trials, is that the modified Rankin is not exactly the greatest scale to use when judging these patients, because there's not a huge number of them that are able to walk, and that already gets you a modified Rankin 3, so the use of that outcome measure is a little bit questionable, but nonetheless, is what was done. So 11% versus 14% at 365 days. Now, one other thing I want to point out here is that the end of treatment volume, so the end of the 3 days of giving TPA, this volume had a graded effect upon both how the patients did and how they did at 180 and 365 days. And so you can see that the patients that had less than 10 cc's of residual clot by far did the best. Patients with greater than 35 cc's did the worst. This slide I meant to take out, but I left it in there. You can see that there's a big financial impact on this. So that's when I was saying earlier that there's multiple ways of judging success in intracranial hemorrhage. This is one of them. Length of stay and hospital costs, even if the patients aren't making a huge clinical recovery, that may be an outcome all in itself. And then this is what they looked at here when they did their analysis from MISTI. Finally, they showed this. So the patients that had less than 15 cc's of residual clot volume were about a third as likely to be ranking greater than 3. So this is the summary here. 14% improvement with modified ranking 0 to 2. 38 days fewer in the hospital, $44,000 savings per patient, and less patients in long-term care. So what does it mean? It just basically means that by reducing the clot size, patients did better, and volume reduction matters. That was Dan Hanley's basic premise at ISC. So I'm just going to talk briefly about the current area here, and I was going to talk a little bit about how do you go approach this and develop a surgical approach. I don't think we need to talk quite as much about that, but how are you going to approach a hemorrhage like this? Is a putational hemorrhage. Are you going to go through motor? Are you going to go through speech? Are you going to go through frontal association fibers? Where are you going to approach this, and how are you going to try not to damage things further than what they already are? You can come up with sort of an algorithm here, and I'll just mention a couple of things that I think are important when you're looking at minimally invasive strategies. The main one being the ability to obtain hemostasis, and so the reason that most of these studies didn't do early intervention, meaning within hours of coming to the hospital, is because the rebleed rates were very high. So if you go and evacuate a hemorrhage and you don't have a good way to control whatever it was that's bleeding under there, it's going to just recur. And that's what they found. And so you have to have a way of dealing with this. And you really want to have minimal damage to the normal structures. And then all of our goal is early discharge to rehab. I met a few of the rehab people that were here today, and this is the one thing for sure that we know that these patients do better is if we can get them to rehab earlier. And so getting them out of the hospital, that's the other part of the goal. These are the two devices that we've used in Cleveland. This one on the left here is it's called BrainPath. It's made by a company called Nico. It's basically this plastic sheath here that's 13.5 millimeters wide, and it comes with this trocar. This is how you introduce it. This other thing here is called the Apollo wand. It's made by Penumbra, and it's a much longer wand than this, but it's cut off on the picture. It goes through an endoscope. And has a little oscillating head on it that's supposed to dissolve the clot and be useful in clot removal. One of my partners used this device for about 10 cases, and we've since have not used it anymore. It basically relies on neuroendoscopy, and for neuroendoscopy to be very successful, you kind of need a potential space there, so we mostly use that inside the ventricles. This device is FDA approved for interventricular hemorrhage, and it seems to work decently well for that, but for intracerebral hemorrhage, like I was showing, that cavity collapses and you can't really see anything with the endoscope. I'll show you how it kind of works here, but that's about it. So the patients prepped here, we use brain lab stereotaxis. This is what the sheath looks like. So it's a very small sheath. The advantage of this particular approach is that it is truly minimally invasive. It can be done through a burr hole. The other one I'm going to show you cannot. This is basically the setup. Just find a trajectory in the head and place this sheath. And then this is this wand going through an endoscope. And let me see. And then basically you're looking on the screen here, and you can see this wand going through this small sheath. And this is about all the view that you have here. So this white stuff that you can see, that's normal brain. This is the clot, and this wand can it's supposed to be able to pulverize the clot. In our experience, we had some trouble with that, but it works pretty well inside the ventricle. So that's kind of what that device does. This was a case done by one of my partners, a 67-year-old man with hypertension. His NIH score was 10, his GCS was 14. So he was, in terms of trying to figure out patients that are good for operative intervention, some people might not want to operate on somebody who has a GCS of 14. The other caveat to that, though, is that on hospital day 3, their GCS is probably going to be 10 or something because there's going to be a lot of swelling. And so our preference has been to intervene early. He was a little drowsy and apraxic, so they ended up taking him for this Apollo procedure. This was the scan on admission. So it's a decently sized hemorrhage, but it's in the right frontal lobe, so the patient was not having a huge problem from this at the time. This is the angiogram. You can see early on we got a lot of angiograms on these patients to make sure we weren't dealing with some vascular pathology or something that was going to blow up on the minimally invasive approaches. I tend to use just CT angiogram now, but you can see a large shift of the intracerebral arteries here. So this could be another problem. You can get strokes from this. Same thing from the other side. You can see the large shift there. And then this is, I think, another video of the procedure. I'm going to skip by that. So this was interesting here because they had about a centimeter, a little bit over a centimeter of midline shift on the initial scans, and the post-op scans that was reduced to about a couple of millimeters. Now, the outcome on this, I think any of us would argue, doesn't look that great. They did 3 passes with this Apollo device. The hematoma went from about 80 cc's to 40 cc's. Now the patient did do pretty well. He was up eating breakfast, he was intact, the family was happy. Patient ended up going home and did fine. Now would he have done that otherwise is that's what we need to answer here. That's been the criticism of a lot of this stuff. A group in South Carolina and Charleston studied this device in 29 patients. What they basically found was they were getting about a 54% reduction in the clot volume. As I showed you earlier, they had very few patients that actually were below that 15 cc cutoff. And you're comparing different techniques, and so that maybe the 15 cc's doesn't apply, but you have to have some kind of target, so that's what we're kind of looking at. So their post-op volumes were, the mean was about 22 cc's. So they had a couple of complications and 4 deaths, which is probably about what you expect out of this type of population. This other approach, so the difference here is that this tube, you have to be able to look around, and so you have to be able to move the tube. And so we have to do this through a small craniotomy. I'm a skull-based guy, so the more bone you take, the better as far as I'm concerned. But so some people have criticized this because it's not truly minimally invasive, although it is minimally damaging to the brain structures. Because although we open a lot of bone, we only enter the brain through a small access. We placed this with stereotaxis. Originally people were suggesting to get DTI imaging, that's the tract fiber imaging, to avoid some of the important tracts. I don't do that anymore. It's too difficult to get MRI on an urgent basis, so I haven't been doing that. And then it's endoscopic or exoscopic visualization. We can do that through the same operative microscope that we use for our other cases. This has been our protocol. These patients' anticoagulation reversal is obvious. The guidelines suggest a hypertensive management less than 140. I've been using CT angiography, which you can also use for stereotaxis, so I give my patients an urgent CTA. And then we take them to the operating room as soon as possible. Now the advantage of this, which I'll show you in a second, is that through this 13.5 millimeter tube, these are similar tubes to what some of the guys will use for spine surgery. So you can actually use instruments through them. So if you find something's bleeding, you can treat it. And I'll show you the data on that in just a second. This is about the best slide I have here. So the intracranial pressure, it kind of shows you what goes on in these hemorrhages. So this was not a large hemorrhage, about 35 cc's, but this is what us putting this tube in. One of my residents videoed this on his phone. And so you can see what happens when you take this blue trocar out. It's like a volcano. So that's what it is right there. I made another video here just to show you kind of what we see. It looks huge. This is magnified quite a bit. So these instruments are just a couple of millimeters big here. So this is the tube. It's 13.5 millimeters. This looks very, very nasty, putting that big thing in there, but it's not that big. And then this is what we see through it. I sped this video quite a bit, just in interest of time, but basically you can see a similar things to what you can see through that other one, but see, this is working with a bipolar here, so if you see some vessels, this is actually a thalamic hemorrhage, so there's a few little perforating arteries there that were bleeding, and you can put these curved tip bipolars in there, you can treat these vessels. We line the cavity, and then we remove the tube. These slides are super busy. I have another summary slide at the end, but this is our experience so far. We've done now 27 patients with this technique. And so what we found, interestingly, we found about 60% of them have had intraventricular hemorrhage, and about 35% of them had hydrocephalus. I'll show you this summary stuff here in a second. Let's get past that. So 65% with intraventricular hemorrhage, 35% had hydrocephalus on presentation, so we treated those with drains. This time here, we can definitely do better with this. So we're kind of working on that. This is the other thing. So we found, in 65% of the patients, we found a bleeding vessel. So those were all patients that were candidates to have rebleeds if it was done by another means. And our average pre-procedure volume was about 50 cc's and post-procedure 2.6. So we didn't have any patients that were over that 15 cc residual. So we had 96% of the clots out. And the length of stay was another place that can be improved. I don't know how things work around here, but in Cleveland, my patients tend to sit in the hospital for about 2 weeks waiting for discharge, despite the fact that they're medically ready to go. So this number is a little bit skewed. Most of these patients were kind of sitting around waiting for insurance approval. And so what we found in terms of the NIH scores, they didn't change too much, and I'm expecting that hopefully at 6 months or 1 year we'll see some difference. But in terms of GCS, we helped with the ICP, so their intracranial pressure was reflected in their improvement in the GCS. A couple of brief cases. I won't spend really any time on these. This is an older lady, but she was globally aphasic and hemiplegic when she came in. I wasn't real keen on operating on this, but one of my partners sent her there specifically for me, I guess. And so I did it. This was the result, and this was the result at 10 weeks. But interestingly enough, even at her age, we did this case early. At 10-week follow-up, she had conversational speech. It certainly wasn't perfect, and she was able to walk. So we'll see how she does in the future. This one it was a slightly interesting case. The other thing you can treat through this approach, this actually ended up being a hemangioblastoma. This was a tumor. So we resected the tumor using the tubes, and this patient went home on post-op day 2. This was another lady. So this was I think the patient that we need for this type of case. So this was another putamenal hemorrhage, young lady, 49 years old. I did this case right away. She did stay in the hospital for a while because you can see she had hydrocephalus and she had intraventricular hemorrhage. But we got a pretty good result here, and this was a result at 6 weeks. She was discharged after we removed her ventriculostomy, and when she came back to see me, her NIH was 0, and she returned to work. And she started hemiplegic. So I think these patients where the internal capsule is displaced medially, I think that this is the ideal patient population. And then one other patient here, just this was a patient with a cerebellar hemorrhage. It's the only one that we have got in the last year or so with a cerebellar hemorrhage that we could try this. It worked very well. She was discharged home and quickly and did very well. So in terms of the future here, I think short versus long-term outcomes, we're in the process of collecting our longer-term outcomes on these cases right now. There's a lot of medical economics that goes into this. And obviously the patients are a little bit higher upfront cost because of surgery, but in terms of their length of stay, it ends up being significantly less. And then our patient selection, really, we're working on that because obviously not all of these patients are going to get the same benefit, and which ones are the best remains to be seen. Spot sign is something that is on a CAT scan. You can sometimes see a bleeding vessel on a original CTA, and those are obvious patients that are good for early intervention. And then some of the way that we do the procedure, we may be able to improve as well. There's a couple of trials that are going on with this currently, so we may see some results from some of that, hopefully in the next year or so. And then improvements in getting our patients to rehab. That's kind of what we're after there. So I have just a couple of questions here. I would have made them a little bit more philosophical after seeing the other guys, but anyway, this is. I'm sorry. So 50%. That's a very high mortality problem, so that's kind of why I became interested in this. The current AHA guidelines support the surgical intervention as the primary therapy in only patients with cerebellar hemorrhages or infratentorial hemorrhages. True or false? So it's actually true in terms of the guidelines. The only procedure where they recommend surgical intervention is cerebellar hemorrhages, but we're working to hopefully change that in the future. So this is off of those MISTI slides. I went through those kind of fast. I'll leave it. But in terms of the patients that had better ranking scores at 1 year. The absolute difference was so 14%, yeah, perfect. 11% at 6 months and 14% at a year. And then the target that we're going after here, in terms of clot volume reduction, 5%, 15, or 5 cc's, 15 cc's, 20 cc's, or 30 cc's. So yes, 15 cc is a magical number there. Whether that's going to apply to anything besides MISTI is yet to be seen, but that's what we were targeting there. So the primary requirements for a successful surgical approach, I kind of went through that quickly, but basically, if you read through those, essentially all of those are the things that I had on that slide. So. So thank you guys very much. I appreciate the attention.